All right. So, well, good evening if you're joining us online here. We're going to get started here right at 7 o'clock on the dot here. And I also want to give out a little warning. I'm going to cross over here and go to full screen and let you know that we are having some storms this evening. So I apologize if we have any technical difficulties. You may hear some lightning in the background. We've already had hail, but we have some people watching out for severe weather. So just to let you know, if you see any glitches or anything flash, we will definitely be recording this. So, all right, we're going to get started here in just a sec. All right, so cross over here. So again, welcome. This is Keely John Booth, and coming to you from the Orthobiogen Clinic here in Oklahoma City. And we're going to talk tonight about shoulder pain and shoulder injuries, and two really of the most common things that we deal with routinely, almost daily. We have patients come in and they're dealing with shoulder pain, rotator cuff, and labral tear issues. And we're going to kind of get into what those are and help you understand. A lot of people that aren't really sure about what these structures are in the body and how they really can dictate what you're having, what you should have done, and really how to go about, addressing these things. So we're going to jump into that. So, and then we're going to handle, I routinely get asked about arthritis as well, but I think there's a lot less confusion about what arthritis is versus what rotator cuff and labral tears are. So, and I really like to start with rotator cuff and labral tears because many people, that's your first injury that you start with, and then things start to lead to other areas. So, all right. So again, my name is Dr. Keely John Booth. I'm a University of Oklahoma graduate, so Boomer Sooner to all you OU fans. And we have a few here supporting us tonight that are adversarial to that. So, but we'll talk during football season. We're in rebuilding mode. So, but I'm a board certified anesthesiologist, interventional spine and joint specialist, really focusing on the treatment and diagnostic modalities to help you find out what's going on with your musculoskeletal system. And that has been a passion of mine since I was in medical school, and really trying to figure out how can we help people, the fascinating machine that is the body, and all the complex things that it can do. Just a great really field for us, and we're really having a lot of advancements in this field. I talk to patients every day. It's such an exciting time in our field because we're coming up with advancements and modalities that allow us to more minimally invasively impact patients' lives in very real ways. And so, and again, that's part of what we'll talk about here in a little bit. I've been around for a little while, so 21 years of experience in medicine as a physician, and ultrasound guidance. One of my early passions, one of the very first procedures I ever learned to do was ultrasound guided injection, as well as X-ray guided treatments is a big part of what anesthesiologists do. A lot of people don't realize the depth and breadth of anesthesiology in all of our subspecialties, and how we bring together, physiology, pain medicine, understanding how the nervous system perceives pain, and then getting into how do we actually get in there without causing any significant tissue damage and actually get to a particular spot. So, and then we even go into critical care medicine, of course, obstetric anesthesia, pediatric anesthesia, neuroanesthesia. And so lots of subfields, and it's such a vast field. And I feel fortunate that I've chosen something that can impact lives in the way that we've been able to in our field. And I look forward to the opportunity of helping you avoid surgery and figure out first and foremost what's going on and what your options may be. All right, so many of you out there are living an active lifestyle, doing the things you love, whether that be here, we've got some examples, and I chose this kind of collage of images to let you know all the walks of life that suffer shoulder pain. Depending on where you look, shoulder pain is and shoulder injuries rank extremely high on the list of things that people bring to their doctors for help. The lifetime incidence has been rated at as high as 60 to 70% for patients that you would experience a shoulder problem at some point in your life. And so extremely high. And so I think a lot of us can relate to that at some point in our lives. So and because of how much we rely on that movement for just day-to-day activities, try to go a day without using, either arm, it's pretty tough. So kind of know that inherently. And then, I talk to patients a lot about, what's really bringing you in. And a lot of times they're telling me, yeah, it started kind of aching, would come and go. But the thing that brings them in many times is it stops them from doing activities like this, or the other one is it starts interfering with your sleep. You roll over in your sleep and you feel that pain, and boy, it's waking you up, and you don't know what to do, and you can't get comfortable. And so you really start to seek out, okay, well, I want to go, find out what's going on. So, all right. So now you have this shoulder pain, what are we going to do about it? So very familiar. So we're going to start off here with shoulder rotator cuffs, and I'm going to go through a little bit of anatomy. So bear with me, because I think it's important for you to understand what this structure, the shoulder, this fascinating complex structure, can do. And it's a really fascinating joint. All right. So in general, what is a rotator cuff? I get a lot of patients that get confused about that. Is it rotator cuff? Is it cuff? In medicine, it's rotator cuff, so C-U-F-F. And this is simply an area of tissue that's essentially made up of multiple muscles that are grouped in and around the shoulder, and they surround the bone in your arm. So right here in your arm, those muscles come together to form essentially a cuff around that region. And I'll show you that here in a minute. And then, the idea is to essentially what we call the glenohumeral joint, which is here. It's simply the main shoulder joint. And it's important to know that we have two critical joints there in the shoulder, really technically three, but we talk most commonly about the two, one where the arm bone, the humerus, interfaces with the shoulder blade. And then we have the collarbone or the clavicle bone as it meets the shoulder blade as well up on the top. So, all right. And so and the rotator cuff is in very close proximity to those joints and helps those joints function properly. And you can see a list of the muscles here. We don't have to get too detailed, but the big one you need to probably know about, because the bulk of the damage when people come in is in the supraspinatus. This is a super common area. The overwhelming majority of rotator cuff tears are going to exist in that. And there's some reasons for that. One primarily is it's just a naturally weakened point, and because it takes a lot of the brunt of gravity and movements, and it's a relatively thin muscle, that tendon can get damaged pretty easily. All right, so let's talk about, I'm gonna turn that off so you can see. So we talked about the humerus. That's essentially this arm bone coming down. So this is the right shoulder, and you have the head of the humerus that interfaces right here. And then you've got this rotator cuff coming over the top. Now, this is the supraspinatus, to be accurate. So this particular image doesn't show all of the muscles. We can get to that here in a minute. But it's important to know how that interfaces there. And then you see this little piece of bone coming off called the acromion that's actually part of the shoulder blade. And then again, you see the collarbone coming across. So you can see how these structures really are all closely aligned. So we're going to jump over here to anatomy here, and I'm going to show you some 3D graphics. And so just kind of show you. So I've kind of got our guy, he's a little bit skinned here. So sorry to startle you for those of you that weren't expecting that, but we wanted to get him ready to go for you so that we could actually show you some very interesting things here. And so, so basically what you'll notice here, as I zoom in, I'm going to click on that. Now I've got quite a lot of muscle here. So all the red areas are muscles, and I'm going to click on these to really show you that is the supraspinatus. And we're going to zoom in to that. And you can actually look over the top of the shoulder, which is why I love this application. You can see how far this goes over to the shoulder blade. And we're going to come down and look across the back. So if someone's massaging your shoulders and they put their hand on your shoulder and they put their thumb right there, that's about where that thumb is going to land if they're massaging your shoulder. So you're familiar with that. And that typically feels pretty good when someone does that. And that's massaging that muscle right there. And then down just under that, you've got the infraspinatus, the second most common one that we're concerned about in terms of causing pain and injury. So these two are critical. So if you were to raise your arm up and stretch out like this, okay, that's exactly the muscle groups that are doing that. And you can see here why we call it a cuff. And I'm going to do a thing where I can actually multi-select and kind of give you an idea, why we call it a cuff. So I'm multi-selecting all the tendons that make up, well, not that one. Try to get that selected there. Okay, now I've got it. And now I can actually isolate this and watch what happens. So the bones will disappear and then you'll see just the muscles. So see there? So you can really see how it almost reaches out like 4 fingers and grabs that arm bone. And that is what a rotator cuff is. And I really think this is just a great illustration to help you understand. And again, this right here is the one that gives us the most trouble over the top, and then the second most, and then third most would be this subscapularis here. There's on the underside, and then the bone literally fits in between. So if I go back, you'll be able to see that here. And but anyway, just wanted to spend a little time there so you guys can see that. All right, so moving on. All right, and I apologize, I can hear the hail coming down as we speak. So hopefully you get your car inside and protected from the hail. So, all right, so rotator cuff tear. You know, a lot of people think, oh, I've got a rotator cuff tear, and they're imagining this. Okay, so they're thinking, boy, this rope is just torn apart or it's completely intact. That's just not the reality that we see in practice. And anybody who actually works on the shoulder really gets a much more intimate understanding that there are many, many levels in between these. And let me show you what I mean. Okay. The reality is more like this. And so what we're looking at here is everything from a completely intact to a essentially slightly rough, right? This is kind of some early fraying, we would consider that. And then here it's a little more, and then you can see, boy, you're just barely hanging on by a thread, and then you get a rupture. It's actually much less common for the average person to go from the top to the bottom, okay? You just don't typically see patients go from one to the other. But when you have this fraying and this tearing, it does progress to a point over time, typically, that can get to this level. So if we can catch it when we're back here, we have a much better chance of healing that with a conservative methodology. Once it's to this point, I'll be the first to tell you that, a retracted, complete thickness, tear, and retraction of the tendon is going to be, difficult or really impossible to repair using a non-surgical methodology. And also the time clock starts ticking on that once it's a complete retracted tear. That's why diagnosis is important. You don't want to sit on this because we want to catch it back here before it becomes this. And then if it stays like this too long, your recovery, even with surgery, the outcomes are to go way down. All right, so rotator cuff anatomy, we kind of went through that and really showed you all that. So that's kind of a recap. All right, so a couple things from this rotator cuff surgery versus conservative care. And this is what there's medical research out there. And this is just a selection to kind of help you understand where we're at in this world. So should you have surgery versus conservative care? And I want to explain conservative care for a second. Conservative care is essentially you are going in having basic things like over-the-counter medication, physical therapy, some maybe home exercise plan, and doing some pretty basic things. It doesn't involve advanced interventional treatments. It certainly doesn't involve orthobiologic care. and that we do at Orthobiogen and using the Regenexx techniques. And so this is just comparing very basic things that everybody really probably has access to. And what's interesting is that they found in this study, right? And it's important to know that they did a comparing a surgical repair with conservative treatment for degenerative rotator cuff tears, a randomized controlled trial, and they did not observe differences in the functional outcome. Now think about that. These people went under anesthesia, general anesthesia, and they were no better off at 1 year in terms of their functional outcomes than what their peers were that simply did home exercise, physical therapy, and maybe some over-the-counter medication. So that's fascinating. And that's there's good literature out there that shows this. All right, this is a different article, and they talk about where the results suggested that a 1-year follow-up, again, operative treatment was no better than conservative treatment in a non-traumatic supraspinatus tear. Again, most common type, far and away. If you've got a traumatic tear that just happened and you were doing an activity, we're not talking about that situation. Those are different and they really need to be looked at. But if it's something that came on relatively gradually and now you're starting to notice that and it's with you for weeks and months, that's going to be a non-traumatic tear in almost all instances. Okay. All right. So what are the orthobiologic treatment outcomes look? When you start looking at Orthobiogen and using Regenexx techniques, we are able to generate, one, we have a lot of data behind what we do. So as a network of providers, we're currently tracking at Regenexx 6,141 patients. Okay. So let me say that again. Over 6,000 patients are currently being tracked for functional outcomes and improvement in pain levels. And that tells you how many, that's just a fraction of the total number of patients that have been treated, because once a patient drops out, we don't count them as being active in the program for monitoring. And but we've done as a network tens of thousands of shoulder treatments. Okay. And this is specifically for patients that are undergoing what's called the SD procedure, utilizing bone marrow, which contains stem cells, and that is precisely injected using very specific protocols and expert care to put that in place. So here you can actually see, and I'll go ahead and drop that out, and so you can see the whole graph. This is actually the latest data. I literally pulled this down today. You can see that it was updated very recently, April 18th. So fresh off the presses there. And these are the outcome data at 1 month, 3 months, 6 months, a year, and going out to 6 years. So what's fascinating is as you track this, boy, patients just keep getting better. And the outcomes for shoulders on orthobiologics are some of the best that we see in orthobiologics. I actually tell patients, I was telling a patient last week that I get excited when we see someone come in that is a good candidate and they've got, even a full thickness tear that's non-retracted. And, because we get great outcomes for patients in that situation, and they're looking to avoid surgery. And I'll tell you, the other thing is the recovery time, right? That's what a lot of you are looking for is, hey, I can't be, with what I do for a living, I cannot be in a sling for 6 weeks. There's just no way, right? I would have to shut my entire practice down and hope that I had, patients and staff to work here when I got back, because it's just not possible. So that's another part of the impracticality, of surgery that you have to kind of think about. But you can see those numbers, and this is, again, functional and pain improvement and patients continually getting better. And you just do not see this with traditional approaches. All right. So, and then, how do we compare this, in terms of recovery? So our Regenexx SD procedure, you're looking at returning to your daily routine in roughly, say, a week or less. Almost all our patients get back to baseline pain levels, pre-procedure pain levels, in less than a week. And then typically returning to sport in 3 to 6 months. And then over here, 1 year, on the surgical side. And you can see the 6 weeks returning to routine because, again, you've been in a sling the whole time. So you look at that and the anesthesia, all of these things, these are the critical factors that make people really contemplate, hey, how can I maybe avoid that, right? And so that's a great way to go. All right, so we're going to jump into some questions. And so Amanda, our assistant here, is going to help us with some of the questions that are coming through as we're talking this evening, and we'll kind of jump in here and answer some of those. So our all right, first question is, how long will it take to recover? And I'm, let's see, kind of a two-part, and it says, do I have to stay in a sling for a month? Absolutely not. So matter of fact, that was a perfect question. Maybe they put that question in before I got to that last slide. So I'm going to go back to that slide and show you a comparison. 2 to 5 days for getting back to work really is what we typically see. And then again, sling time for our patients. My typical patient is in a sling maybe 2, maybe 3 days. And you're actually able to take the arm out. And remember, the key factor there is that you are not destabilizing tissue when you perform a orthobiologic procedure. I explain to patients, the largest needle that I'm going to use on your shoulder is smaller than the needle that we use to give you IV anesthesia, right? It's remarkably small, and about a week out from the procedure, people have difficulty even seeing any evidence that I ever went in there. And I tell people, and there's another part that kind of explains this, when I do a procedure for the shoulder, and let's say you, for whatever reason, you had to have surgery, or you saw a surgeon, a month later, 2 months later, the surgeon won't even know that I've been there. That's how light of a touch and how small and how specific we can be with our procedures. We can literally feed our treatment needles through the eye of a sewing needle, which is less than a millimeter in size. It's about 1/3 of a millimeter. So we can place needles with that specificity. Whereas on the other side, surgery, you have to make an incision, in order to get in there. So that kind of gives you an idea. And then recovery time, I'm typically releasing patients, depending on the level of damage to your shoulder, anywhere from 4 to 6 weeks back to normal activity. If it's a return to sport situation, it's going to be a little longer, depending on how bad that tear is, before we feel confident and safe to get you totally back to that. Let's say if you're, playing tennis, baseball, other types of things. So, all right. So, any other questions? All right. So we're going to move on. Shoulder labrum, AKA the glenoid labrum, which gets kind of confusing. This is essentially the same thing when you see physicians, orthopedic surgeons talking about these things. So just understand that these are used kind of interchangeably. And it's probably important to note that if you just say labrum, that's not specific enough. You just say labral tear. Well, you've got labral tissue in your hip as well. And it functions very similarly to the shoulder, but you want to make a clear distinction between the two when you're just saying, hey, labral tear, because I've actually had patients in my office that have both at the same time. So that does happen. All right. So again, shoulder anatomy, referencing back and giving you an idea of where we're at. So right here, you can see that glenoid, and we say glenoid labrum, which is the rim of tissue around. So we'll define that for you here in just a second. But again, I wanted to show you that anatomy. This ring of tissue right here is what that is. And I've got here, it's a good way to see a 3-dimensional understanding of how that ring sits around that arm bone. All right. So what is the labrum? It's a ring of fibrocartilage around the edge of the articular surface of the bone. It basically increases the surface contact area to help stabilize the joint. So you can imagine you've got this nice surface that's smooth, and it can support and hold that in. So when you dislocate, right, it's one of the things that resists a dislocation of the shoulder. So if you have a tear, sometimes that comes secondary to a dislocation, or something, you've hit your arm, or you've thrown too hard, or you've maybe been in a car accident and you were holding the steering wheel. All of those things can cause tearing in that tissue. And just like we use the example of there's small tears, big tears, and we kind of add this component of circumferential tearing, right? And I've had patients actually have what we call 360-degree circumferential tearing around the entire labrum on both sides simultaneously from a trauma. So it can get that bad. And that patient was treated with orthobiologics instead of surgery, because there were a lot of other things going on and they had to try to avoid surgery. and we had really very good success. That patient was actually able to return to her activity of choice, which was she was a professional dog trainer. And so she actually brings animals to, and she runs with them and trains them, and she has people that work with her. And she was able to get back to that in a matter of just a few months after being in a severe head-on collision at 75 miles an hour with bilateral circumferential tearing of her both labor tissue, so on the shoulder there. So all right, so moving on. So the glenoid labrum here talks a little bit more about that, and gives you some more. So basically, we talked a little bit about that. It kind of deepens that cavity, gives you a little bit more stability in there, and supports that shoulder. All right, so what if you ask a surgeon? I kind of did this in preparation for tonight. I said, okay, if I go out and ask a surgeon, what is the success rate of labral tear surgery repairs? And this is an actual screenshot from, and I've referenced it there at the bottom, from an orthopedic surgeon's website. And this is what apparently this is what they tell patients, is that the success rate for labral repair ranges from 85 to 95%. The goal is to achieve a shoulder with no pain for lifting, throwing, and overhead activity. Well, that sounds fantastic, right? Why wouldn't everybody want that? I mean, no, that's outstanding odds, right? And if that were the case, I would send probably every patient that I found a labral tear in straight to this doctor, because he is actually achieving levels and outcomes that are beyond anything published in the literature. So it seems like we should have great confidence here. And this is kind of what I want in my, orthopedic, doctor is, hey, 85, 90%, great odds. Well, let's talk about what the literature says about the same repairs. Okay. So on average, 54% of your, and this is, we're getting into some lingo here, but suffice it to say, these are interpreted MRI images, right, after a surgical repair. So you see that's an MRI interpreted after a slap repair. It's a type of tear, and it says, hey, only 54% of them were healed, while 46% as having a retorn slap tear. So wait a second, that's not 85, 95%, right? And I looked, and I can't even find a research paper of any quality that says that they can repair at 85, 95%. I just can't find it. I don't know. And of course, there's no reference on the website. So, I don't understand how you get that and how you can say that when there's no support for that in the literature. So just to kind of let you know. And sometimes people are just speaking anecdotally, but if they have outcomes that good, they're going to be very famous, and they should be known worldwide. And we should send every patient to that facility in that clinic, and he should teach that technique to every doctor he knows, because he will save a lot of people a lot of trouble. But unfortunately, that's not what we see in practice. So overall, this is an important fact. That's why I underlined it. Only 43% of the studies even had 100% agreement across interpretation. So they had different doctors interpreting healing versus non-healed, who retore and who didn't. And less than half the time, they even agreed on whether it was healed or not. So you see the challenge here. The reality, right, where you want to have confidence, the reality is more like, we don't know, right? Because this is what we get from the literature when they look closely at these things. They cannot even agree on what a healed post-surgical repair, whether it's healed or not. And that's pretty telling, I think. So, all right. So we're going to get into, how common are these tears, right? This is another feature I think you need to understand. Superior labral tears are diagnosed with a extremely high frequency in 45 to 60-year-olds and in an asymptomatic shoulder. Okay. So you're saying, okay, common. What's common? It's relative, right? So let's put some numbers to that. So this study that looked at subspecialty trained, orthopedic specialized musculoskeletal radiologists were able to go in and say, hey, what percentage of these patients that had zero symptoms, okay, their shoulder's fine, between the ages of 45 and 60, how many of them had tears? Well, one radiologist said 55% of them had a labral tear, and and the other radiologist said 72% of them have a tear. So that's our range there is 55 to 72%. So again, they don't agree, right? There's almost a 20-point differential on whether or not we even think they have a tear. And understand that this information is being used to determine whether or not you go to surgery. And the variance, in my experience, is even wider among surgeons. Okay. When a surgeon looks at it, they may just say, oh, radiologist was wrong. This looks like a tear and I can see it here. And hey, and I don't disagree. I find things like that as well. Radiologists are busy. They kind of scan, go too fast and maybe they miss something. So, and this is why you'll find that Regenexx doctors, Regenexx trained physicians, and here at Orthobiogen, we never base our treatment decisions on a single imaging modality. So we actually have at least three that we use routinely. And so, we look at this from multiple angles. We have the capacity to do and routinely perform. One thing I always do on patients for shoulders is we're going to evaluate you using high frequency ultrasound that allows me a higher resolution even than an MRI. And we can see things as small as a millimeter on the screen when we find defects that are difficult to be seen. And sometimes they may look like just, tendon inflammation. And in fact, they're actually small tears that we can pick up in ultrasound. The other thing is that we have a dynamic ability to move the shoulder around, and the patient can actually show us, and we can actually palpate at the same time we're doing imaging to see, does that actually corroborate the pain? Does that link to the pain? So, all right. So, so what treatments are commonly offered to those patients when, they're looking at, in the traditional world, it's physical therapy, blind steroid injections, arthroscopy, as well as labral repair surgery, sometimes, open surgeries. They're doing more and more, through the small scopes, the arthroscopic procedures. But again, surgery is surgery. There's risk there, anesthesia, all those things you have to worry about. So you can see, this is one thing we talk about a lot is all of this is moving in one direction. And as you see the gentleman here, not much has changed in the approach in, 100 years of looking at these things. Okay. We're still basically taking, different forms of expensive rope and tying things back together and essentially trying to get them to function like a normal shoulder. And that's challenging, right? So we want to try other things. All right. So, so at this point, we're going to do some questions about, hopefully they're more labral associated. So let's see. All right. So will I be able to golf after my procedure? All right. That's a loaded question. So I'll tell you, golfing after your procedure will depend on what procedure you had, what the pathology was. Did you have an isolated labral tear? Did you have an isolated rotator cuff tear? Was it a full thickness tear? Was it a partial tear? Did we use biologics such as cell-based bone marrow, which contains stem cells, or did we use PRP? So all of these things are factors that would be very much individualized to you. And then as you're going through your therapy, we're also continually making assessments on your performance to figure out if you're ready. Okay. So I had a patient recently that had a pretty severe tear, and it was actually a full thickness, partially retracted, and really needed the full gamut of what we could do. And essentially went in there with cellular content and lots of rehab in terms of building on that, and admittedly it was several months before we recommended going out and playing golf. But that's in a pretty significant, tear. That's a patient that had they had a surgical procedure, in all likelihood, they wouldn't have been released to go play golf at least for 6 months. So if you're talking, hey, we may be able to get back to, starting to hit balls and things in a matter of a few months, that's a pretty decent trade-off. Not to mention the amount of time that you're not in a sling and all of those things. So, so you really have to look at it case by case. I hate to just make a blanket statement. Sure, you can play golf after your procedure. We do have many patients that play golf, but it's a question of what did they have done? How bad was their shoulder? And I tell patients that it's pretty rare for me to see somebody with just one small thing wrong. If you come in, you've got isolated partial tear, we've seen patients, come in and have a PRP injection, and they're back to their activity of choice in a matter of, 4 weeks to 6 weeks. And I fully release them back to, doing what they're doing. And sometimes they jump the gun on me because they feel so good. And so I don't recommend that, but it's one of those things that, sometimes it happens because they recover so much more quickly. Okay. All right. So any other questions there on that so far? All right. So do we treat frozen shoulders? Absolutely. And matter of fact, most patients with frozen shoulder, our biggest concern is, where I see most of those come from are actually post-surgical patients. Okay. Frozen shoulder, really, and I would say out of the patients I see, about 90% of them had some type of surgical procedure prior to developing the frozen shoulder. Some cases trauma, and rarely just spontaneous frozen shoulder. So in my experience, that doesn't bode well if you've already got a lot of hardware, other things inside that shoulder, because then that begins to limit the effectiveness. But we do, and in certain cases, we're able to go in there. There's an approach we use called hydrodistension, where we actually are able to go in and actually essentially use that joint capsule kind of as a balloon to help peel that off. And that's something that we've seen help patients. And it's akin to kind of doing a manipulation. There's a thing that the surgeons will do called manipulation and injection, where we're actually they'll go to our operating room and just take you to sleep and then just grab your shoulder and move it around, trying to tear those off. We don't do it that way. We do it a little kinder, gentler, and we actually numb the joint, and then we go in and essentially inject that and hydrodistend it, and then we'll actually pull off fluid, because sometimes that pressure alone will cause discomfort, but we're able to go ahead and take some out after we've put it in. And so, but yeah, suffice it to say, we're able to get some improvement with frozen shoulder. And if we can get the inflammation and pain calmed down, get you moving it again, typically we can break up some of those adhesions. All right. And how many injections will you need is a question that just came in. So again, depends on the level of disease, the specific things that you have. So, and I want to make a distinction here. There's how many injections we may do in one sitting for your procedure. For example, if you have, 2 different areas of partial tearing in the supraspinatus and a tendinopathy, tendon inflammation in the infraspinatus, and you've got a posterior superior labral tear, and you've got AC joint arthritis, and I'm rattling these things off because that's how common it is. I see cases like that all the time. Well, given all that, by the time I treat the ligaments inside the joints, inject directly into the defects in the tendons, we may be talking, 8, 10, 12 different specific areas that I need to place biologics. And we have specific biologics that we prep in our state-of-the-art lab. We're the only ones in the entire state of Oklahoma that even do this. We prep different biologics for different tissue because we have data through the many hundreds of thousands of procedures performed at Regenexx that over time have helped us understand what works best in what tissue. So we're able to actually do that. And so in one sitting, you might have several injections, but in terms of the number of times that you come back, that's going to be more dependent on the type of pathology. If you have an advanced arthritis, then we're going to do something called a pre-injection and what we call a bone marrow re-injection, and then a post-injection. So that would actually be 3 injections, 2 of them rather simple treatments that you wouldn't even need anesthesia for. We do those within the span of a single week, and we just have you pop in, get that done. And then, that gives us our best outcome. But in terms of repeat injections over and over, most of our patients actually get one, and that will sustain them for very often years. So, all right. So, all right. So we're moving on. So basically, at the end of the day, we challenge you, if you're out there suffering from shoulder problems, shoulder pain, we challenge you to rethink surgery. You may have been told it's your only option. And I really think that needs to change. We need to change our way of thinking as physicians, because that may be the only thing that a traditional orthopedic provider, has to offer you. But they know that there are other things out there and that there are interventional methodologies. And I just don't think it's fair anymore, to say, surgery is your only option, especially given the outcomes that we're seeing and the frankly lackluster outcomes that we're seeing. And so we really want to challenge the discipline to think outside the box and say, hey, how can we help patients with minimally invasive, low risk procedures that keep you active, going to work, enjoying your life, and especially when you think just physical therapy and over-the-counter medication seems to do about the same as surgery depending on the pathology. All right, so a couple notes I wanted to share with you. Why orthobiogen? We are Oklahoma's simply the most advanced providers of this. We have spent more time, we've treated more patients, we have the most options for patients in this field, and we do things completely backed on science. If your provider is not a specialist board certified physician and they're attempting to perform biologics for you, we have, who you are out there, they are pretending to be something that they are not. And they really have, and a lot of times, not done a great job in terms of how they're approaching this. And I just want to point that out, that we'd love to educate you about if you've gone somewhere and you've checked out another clinic and you say, hey, I want to kind of just see what my options are, get a second opinion. I'd love to see you, to evaluate you and take an opportunity to just show you the difference between what we do. And ultimately, I want you to make the decision that's right for you. But it's critically important that you understand that there's a big difference. And there are some other things out there that could even be considered dangerous when performed by people that just don't have the training to do that. Okay. All right. So happy to meet with you and go over it. And all right. So if you're interested in an evaluation, and I hope you are after listening this evening, I want you to give us a call at our number there. So at 405-697-3436 and schedule your evaluation today. And I always make you this guarantee. You may not be a candidate, and I'll let you know if I think surgery may be your best or only option. We're always upfront with that. I tell patients, look, we don't do Hail Marys here. We're not just kind of, cross our fingers and hope for the best. We back our what we do here with data. And when I say data, I mean the likes of data which no one in our industry has that level of information. So shoulders alone, we're tracking over 6,000 patients with outcome data, as that I showed you earlier. And if you're interested in checking that out, I suggest you go to the Regenexx website, and it's all publicly available there, and you can learn a lot more. And I look forward to next time we're going to try and work on going over the shoulder arthritis, which is kind of the next level. Okay. All right. Thank you guys for tuning in, and we'll see you next time.